Good evening, everybody. And you all are now joining 2020. We, the Human Genetic Society and Human Genetic Unit, fully sponsor for this series of webinar for last couple of months. And the whole program is actually run under the leadership of Professor H.W. Dissanayake, and immense contribution from our Human Genetic Unit also is unforgettable. And for today's academic webinar, now let me acclaim our guest speaker, Prof. Ratna Dua Puri from India. Please forgive me, madam, if pronunciation error comes there. And even in the absence, may I welcome my Prof. H.W. Dissanayake, as well as all the members of our Human Genetic Unit and Human Genetic Society. The participants enthusiastically communicating with us from the beginning of the propaganda of this webinar. You all are warmly welcome. First of all, let me share a few informations with you all. And please make sure that your microphone and the video is switched off. And you can put your questions on the chat box. And another announcement that this webinar is being recorded and it will be available in our Human Genetic Society website as well as the YouTube link. So here my colleague Dr. Vindya is here to brief on our guest speaker. Over to you, Vindya.
Thank you, Dr. Tushara. A very good evening to all of you. I am Dr. Vindya Subasingha, Senior Registrar in Pediatric Clinical Genetics at Achulade Ridgeway Hospital for Children, Colombo. It is my privilege to introduce our speaker for this evening, Professor Ratna Dua Puri. I think she is not a stranger to most of the Sri Lankan medical scientific crowd. Even as a pre-MD trainee, I had the opportunity to listen to her at several local conferences organized by the Sri Lanka College of Pediatricians. So I feel we are really fortunate to have her as a speaker for this webinar. Professor Puri completed her MD in Pediatrics and doctorate in medical genetics, and currently a professor and the chairperson, Institute of Medical Genetics and Genomics, Sri Gangaram Hospital, New Delhi. Her interests carry a vast range, including diagnosis and management of rare disease disorders, specifically within the area of dysmorphology, malformations, fetal evaluation for etiology, lysosome storage disorders, and education in evolving fields of genetics. She has over 100 publications in index journals, has contributed to 15 book chapters, and has won several awards, including Young Investigators Award at the International Congress of Inborn Errors of Metabolism in 2006, FICCI Healthcare Award 2017 to her institute, Dr. I.C. Varma Outstanding Researcher Award in 2019, and many more. Her involvement in the research has been immense, with many completed projects, and some of the ongoing projects are next generation sequencing in critically sick neonates and children with suspected genetic disorders and children with unexplained intellectual disability. She's working on establishing a registry for rare and potentially treatable genetic disorders as well. She's the founder member of the Society of Indian Academy of Medical Genetics. Her contributions to the field of genetics as well as pediatrics dates back as past secretary, genetic chapter of the Indian Academy of Pediatrics and past president of the Society of Fetal Medicine. It's with pleasure now I invite Professor Ratna Dua Puri to speak on genetic approach to hypotonia in a neonate and child. Over to you, madam.
Thank you very much, Dr. Vindhya and Dr. Tushara, for this very kind introduction. And I would also like to thank Dr. Vajira Desanaika for the privilege of being able to address all of you. I've been to Sri Lanka many times, and it's like a homecoming, and it's a pleasure to be able to share some of our experience in my center with all of you. So thank you very much for taking time out, and it would be of benefit to most of you. So I would share my screen now, and I would request that if everybody would switch off their mics so that there is no interference in the sound. And you are welcome to put in questions in the chat box so that we can address them at the end of the talk. So the topic that was given to me today was genetic approach to hypotonia in a neonate and a child. I just wanted to confirm if you can see my slides and can hear me clearly.
Yes, madam, we can see and we can hear you.
Thank you, Tushara. So, you know, hypotonia in a neonate and a child is something what we very often name as a floppy infant. During our, rounds in the ward or in our clinics or in our OPDs when we are examining young neonates and infants. And we know that it is a great diagnostic challenge. And the reason for that is that the etiologies are very varied and extremely extensive. At the end of the day, the aim when we are examining a floppy infant or neonate is to make a clinical diagnosis to harness the best results with targeted investigations, because we understand that the reasons behind a floppy infant are extremely heterogeneous. So I'm going to really, to catch your attention, start with a patient. So you get a reference into the neonatal intensive care unit because they have a baby who has been born just a couple of days ago. He had history of decreased movements since birth. There is nothing contributory in the antenatal history, and I'm just talking about the relevant positive history and the positive clinical examination for lack of time. The weight was 2.2 kilos, which was at minus 2.7 z-scores. The length was at minus 0.86 z-scores, more or less okay at 48 centimeters. And the head size was at plus 3.6 z-scores at 38.5 centimeters. The child was noted to have dysmorphism. We'll come to the facies later. And he had extreme hypotonia. And in the NICU, they had already done a CK analysis because that is something we do in all neonates who present with hypotonia. And as you can see that the CK levels were high at 1967 international units per liter. The systemic examination on clinical exam was normal and echo was normal. The ultrasound was normal with normal kidneys. So this is the child you can appreciate. He had a large forehead. On the right side, there was microcornea, microphthalmia, and a corneal opacity. And on the left side, there was this huge eye, which was ophthalmos. An MRI was done. And this MRI, you can see, showed abnormalities in the supratentorial as well as in the infratentorial region. This was a Z-shaped brainstem, and we had these indentations at the junction of the, the medulla and the midbrain, and then once again at the pons and the midbrain, and once again at the junction of the medulla and the spinal cord. There was atrophy of the cerebellum and the vermis, and a large posterior fossa cyst, which you can appreciate here. Even the supratentorial region, the cerebral brain matter was greatly atrophic. There was agyria, pachygyria, and we see some cobblestone lesioncephaly here. Now, with this hypotonia, dysmorphism, and cobblestone lesioncephaly, we know that we would think of the alpha-dystroglycanopathies, which is one of kinds of congenital muscular dystrophies. What do we see in these patients? You have brain and eye anomalies, profound intellectual disability, and there is congenital muscular dystrophy. And because of all these, especially the brain abnormalities that you can see, and involvement of the brainstem, there is early death. What is the key thing that makes us think of alpha-dystroglycanopathies is the presence of cobblestone lesioncephaly in these children, along with involvement of the eye. The phenotypic spectrum is very vast. It can range from a very severe Walker-Warburg syndrome, as we saw in this child, to a less severe muscle-eye brain disease. It is an autosomal recessive disorder. It is genetically heterogeneous. So once you've made a clinical diagnosis of alpha-dystroglycanopathy, you would order a panel test or an exome, depending upon the facilities available, to take forward testing all the genes that are related to alpha-dystroglycanopathies. So that is really my introduction to the whole topic as to how do we approach a child who presents to us with hypotonia. So now the learning objectives of my talk would be to distinguish between hypotonia and muscle weakness. What are the differences between central and peripheral hypotonia? A bedside approach to the etiological diagnosis, key pointers to a genetic cause of hypotonia, because essentially that's what I'm going to be dealing with, and what are the appropriate genetic tests to be done. So starting with the basic concepts, we have tone, which is either increased or decreased. If it's decreased, it's hypotonia. If it's increased, it's hypertonia. And what is tone? It is the reduce in the resistance to a passive range of movements around a joint. And if there is hypotonia, the child, so these are the spontaneous movements, when we just observe the child, how the child is lying down, how the child is when we do the various maneuvers, and I'll come to this very soon. So it could be a frog-like posture, it could be a ragdoll appearance, or it could be slipping through the arms. Comparatively, we talk about weakness or power, and this is a measure of the strength of the muscles. It is against active resistance to movement. When we give some resistance, how much strength does that child have to resist and to do the movement despite the resistance? Now, head lag, when an infant is pulled to a sitting position, is a sign of weakness and not of low tone. It's important to understand these concepts. Also remember that enlarged muscles can be weak or strong. Thin muscles can be weak or strong. We have to do all these maneuvers to understand what our child had. Now, these are the maneuvers for hypotonia. You can see this ragdoll appearance. The child is not able to lift the neck or the legs. This is the frog-like posture. And this is the slip through the arms. Because of hypotonia, the child just slips. When you hold the child in this position, the child will slip through the arms. And this is the head lag that we talk about. And this is the pull to sit maneuver. So when we talk about a floppy infant, I had told you, remember, the etiologies are varied, and the etiologies can be right from the upper motor neuron or the central nervous system to the peripheral nervous system. 80% of the causes are because of central hypotonia, and this is characterized by, of course, there would be low tone, the reflexes would be present, the seizures may or may not be present, the children may or may not have encephalopathy, and there is usually associated dysmorphism. Most of the causes in the central would be either there is hypoxic ischemic encephalopathy or some sort of a bleed. There could be drugs that are maternal or neonatal. Then we come to genetic disorders, and then you have CNS malformations. And the details of these I will be alluding to in my next slide. Then we come to peripheral hypotonia, which starts at the anterior horn cell. It involves the nerve, neuromuscular transmission, and the muscle. This is a cause in 20% of cases. It is characterized by hypotonia and weakness with hypoactive reflexes and weakness in the form of lack of anti-gravity movements. Some of the prenatal findings that are associated with hypotonia, especially peripheral hypotonia, would be decreased fetal movements, polyhydramnias, or a breech position. So now you can see that this is a big list. I do not expect anybody to remember the list. Over a period of time, as you see patients, you go back to the list and slowly you will remember what are the common causes that cause hypotonia. But what is important to appreciate is 50% of the patients can be diagnosed by history and clinical examination. Both you and I work in an environment where we have to think about ordering which test. You know, it's not as if we can get all the tests done in all our patients. So thereby, history and clinical examination plays a very, very key role. Then based on the detailed phenotype, etc., we would say, well, these are the differential diagnoses, this is the level of lesion, and this is the test that I would order to take it forward. So now, I've already talked to you about central and peripheral hypotonia, and we are going to go through these one at a time. So central hypotonia could be chromosomal causes, which could be either abnormalities of chromosomal number or deletion duplication. Again, chromosomal and single gene. It could be Prader-Willi syndrome, which is a methylation disorder, peroxisomal disorders, abnormalities of brain development in the form of cerebral dysgenesis, or in some cases, abnormalities of myelination, but this would be a totally different group. And peripheral we'll come to later. So for the history for patients with hypotonia, you would go like any geneticist into details of the family history, draw a 3-generation pedigree, the past medical history, take the prenatal, perinatal, and neonatal details. All those features that I talked about antenatally, were they present? Was there a fetal movement? What was the presentation? Was there polyhydramnias, which could be present because of impaired swallowing of the fetus if there is hypotonia? What were the APGAR scores? But it's important to remember that if the APGAR scores are low, it is not equal to HIE. There are many causes of a low APGAR, and it has to be taken, you know, in a whole based on the presentation and what are the other features. So the other thing to remember is that central hypotonia does not worsen with time, but may become more readily apparent, okay, over a period of time where they develop, you know, hypertonia or seizures. Whereas children who have an injury, say they've had trauma, they've had a bleed, they develop increased tone and deep tendon reflexes very early. Now, remember the first cause was chromosomal. This is something we all know, a child with Down syndrome, and this is related to abnormalities of chromosome number, trisomy 21. And we know that children with Down syndrome are extremely hypotonic, but it is a facial gestalt diagnosis. And if you suspect clinically Down syndrome, you would order a karyotype analysis to look for trisomy 21. Then we come to other abnormalities of chromosome structure, which could be the microdeletion and duplication syndromes, which are identified by MLPA, fluorescent in situ hybridization, or chromosomal microarray. You could use any of these depending upon what is available. Now, this is like a series of children. They are older children, but they present in the neonatal period also with dysmorphism and hypotonia. It is actually a differential diagnosis for Down syndrome. It's a Down syndrome-like faces because they have, look at this, mid-facial hypoplasia. And therefore, they look, when they are young, very much like children of Down syndrome. Now look at this other child. Again, a Down syndrome-like phenotype, but in addition, has severe developmental delay, not attained any milestones, a previous sibling death, and not diagnosed. The chromosomes of this child were normal. But when you see this child also has severe developmental delay, seizures, hypotonia, a large head, and has hepatosplenomegaly. The MRI shows abnormal white matter changes. And in the eye also, there are some findings. So in this case, you know, you're dealing with a recessive disorder. It is not Down syndrome. And because Down syndrome, you don't get so much of seizures and hepatosplenomegaly and changes in the MRI. And we think of a peroxisomal disorder, which is why we order a very long chain fatty acid analysis in the blood. And when we order that, we see that the very long chain fatty acids are increased, the phytanic acid is increased, the pristanic acid is increased, and the plasmalogen in the RBCs are low. And this is consistent with the diagnosis of Zellweger spectrum disorder. So remember, these are all clinical clues. We still have not, we thought of Zellweger and thereby ordered a very long chain fatty acid test in the blood. Now look at this child. There was history of polyhydramnios. He was hypotonic at birth, had not established good feeding or sucking. The birth anthropometry was normal. And look at this MRI. There was partial agyria pachygyria, which was much more severe posteriorly, and there was a thick cortex. And then as this child grew older without a diagnosis, we noted that he was dysmorphic. He had this prominent forehead, some bitemporal hallowing, a short nose with anteverted nares, and he had this downturned upper lip, and he had this sort of, forehead creasing when he cried. So this was consistent along with the MRI picture of Miller-Dieker syndrome. So there you can just do a FISH test because we'll want to look for a deletion of the LIS1 gene. It's an autosomal dominant disorder. So it is obviously the information should be available for you, and then a keen observation and correlation that gets you to make the diagnosis. Now this is again a diagnosis which is actually made in the newborn nursery, because these children have hypotonia, extreme feeding difficulties, abnormalities of genitalia, and antenatally again we'll have features of hypotonia. They could be slightly fair looking, but the key here, which would probably differentiate them from, say, Down syndrome and other disorders, is the poor sucking. They're just not able to to suck at the nipple and establish good feeding. And we would then suspect Prader-Willi syndrome. And all neonates with Prader-Willi behave like this. Once you know it is Prader-Willi, you know it is a genomic imprinting defect, and you would order the methylation analysis in a blood sample, because that methylation will pick up the deletion in the gene. It will pick up uniparental disomy and also imprinting defect. The imprinted gene means that one gene is naturally silent and not functional, and there is naturally only one functional gene in the Prader-Willi region. So if I knock out this functional gene, it is going to give me the disorder. So I can delete the functional gene. I can duplicate the mother's non-functional gene, or I can have a defect in the control of this functional gene. So these three mechanisms of genomic imprinting, which give rise to Prader-Willi syndrome, are all picked up by the methylation analysis. So this is a one good test when we suspect Prader-Willi. So the pearl here is that if you have unexplained poor feeding in a term infant along with hypotonia, there are no other congenital anomalies for us to suspect a chromosomal disorder. The MRI is normal, so that there's no bleeding, there's no cerebral dysgenesis. You would want to think of Prader-Willi and order the DNA methylation study. So that finishes us with a group of central causes of hypotonia. Now we come to the peripheral causes. It could be the anterior horn cell, the peripheral nerve, the neuromuscular junction, the muscle, and metabolic myopathies would be a part of the muscle disorders. So we start with the commonest defect, which is called spinal. So before that, there are various distinguishing features that allow us to differentiate these different levels of involvement that give rise to hypotonia. So we would want to know what is the weakness, that means what is the power, what are the dependent plexus, the EMG, muscle biopsy, and other features. So if you have central hypotonia, so F is face, A is arm, legs, proximal versus distal. So we don't have any face involvement in central hypotonia. You have some amount, the face involvement is predominantly there in neuromuscular disorders, and it is variable in myopathies because you can have the myopathic faces. Now we talk about weakness of the arms and the legs. It is not there in central disorders. There's not much weakness. Their strength is fine. But yes, it is there in the neuromuscular group, and it is maximum in those which involve the anterior horn cell and proximal more than distal. In the peripheral nerve, distal involvement is more than proximal involvement. In neuromuscular junction, they're all involved. And in the muscle, again, there is proximal more than distal. In the in the anterior horn cell involvement, there are no reflexes. In the others, they could be normal or decreased. Whereas in the central, they are normal or increased. EMG is really diagnostic for anterior horn cell because we get fasciculations and fibrillations. We can get some myotonia in some of our muscular dystrophies. Otherwise, and of course for myasthenia, where we get a decremental response. Muscle biopsy is not very useful unless we've got the complete armamentarium of histopathology, immunohistochemistry, and electron microscopy. And in those situations, it is of benefit in the congenital myopathies. And of course, I've already talked about other signs present for central disorders, fasciculations in the tongue that we see for anterior horn cell, the peripheral nerve where we would have muscle wasting, which is very apparent, distal more than proximal in most situations, except for some exceptions, and a sensory deficit. And in the muscle, you would have involvement of the muscle enzymes and some amount of joint contractures. So with that, we know that there are some of these things that alert us to a neuromuscular disorder. So I said that all muscular dystrophy is usually proximal more than distal, except for myotonic, where we have distal involvement much more than the proximal. Fasciculations can be seen, decreased movements, weak thorax because of neuromuscular involvement, and low birth weight. So I'm going to talk about the anterior horn cell disorders, which is really spinal muscular atrophy. Typically presents with hypotonia and weakness. Because it's the anterior horn cell, the reflexes are absent. You may be able to see the fasciculations. The EMG and the NCB is neurogenic. And cognitively, these children are very alert, which is not something that you see in central causes of hypotonia. And what I really want to show you, so this is showing you the hypotonia and the weakness. The children are alert, and you see these fasciculations that are best seen in the tongue because the amount of subcutaneous tissue is less, and you can see the movements of the muscles. And they would have diaphragmatic respiration. It's an important disorder. One minute. It's an important disorder to diagnose because we all know that now treatment is available for SMA. And we look for a homozygous deletion of SMN1. And along with that, we would also want to look at the number of copies of its a very highly homologous pseudogene, the SMN2 gene, because this has great implications for therapy. If you have more copies of SMN2, the phenotype is milder because it does make some protein. And some of the therapies that have now come are dependent upon the number of copies of SMN2. And this is how we test for it. We use a very simple PCR-based test where, because it's a cheap test, where you can look for, and this test can only be done in the affected child because here you're going to look for a homozygous deletion like here. And this is a normal control. You'll get 2 bands. In the patient, you'll get only 1 band. Otherwise, as per the protocol which goes in gene reviews, you can do the MLPA test to look for a homozygous deletion of SMN1 and the copy numbers of SMN2. But to save costs, we do this test because you would want to look at only SMN2 copy number if there is a deletion of the SMN1 gene. So I've talked to you about this. The importance is it's a recessive disorder with a 25% risk of recurrence. You can offer them prenatal diagnosis in the next pregnancy. You can do mutation carrier testing in the at-risk individuals. And we have done a study in my hospital, in my department, where we identified a carrier rate in low-risk individuals to be as high as 1 in 44. And in another center in India, they identified it to be 1 in 38. So the carriers are common for SMA. Then we come to the next group, which is the peripheral nerve. Now these are the neuropathies. So if the nerve is involved, you will not have reflexes. So there is hypotonia, weakness, absent reflexes, and muscle atrophy. It's very typical. It's distant involvement more than proximal involvement. There are many kinds of neuropathies, but those that present early in childhood or neonatal period are the congenital hypomyelinating neuropathies. I'm not going to go into these details, but suffice to say that this is how you would suspect them, do an NCV, and then the test for the neuropathies, because there are many genes that are present, and we would do next generation sequencing, either a clinical exome or a whole exome to identify that one specific gene associated with the neuropathies. Then we come to the group of neuromuscular junction involvement. Here we would really be dealing with the congenital myasthenic syndromes, which is again a host of them. They could be presynaptic, synaptic, or postsynaptic. Okay, and they would present with hypotonia, a lot of facial involvement and eye involvement. So there's external ophthalmoplegia, ptosis, there is dysphagia, weak cry, weakness of the muscles of the face, and easy muscle fatigue and respiratory insufficiency. So there are many genes which cause congenital myasthenic syndromes, but the most common of them are the rapsin and the DOX7 genes. But again, wherever there are multiple genes involved, once you've diagnosed, okay, I think my patient has myasthenic syndrome, I would do the next generation sequencing to take those tests forward to identify which one gene is causing the disease phenotype. Then we come to the next group, which is the muscle disorders. Okay, so amongst the muscular dystrophies, we have a large group of these muscle involvement. They could be the limb girdle muscular dystrophy, they could be the congenital muscular dystrophies, or myotonic muscular dystrophy. Limb girdle muscular dystrophies usually present later, not very early. The congenital muscular dystrophies present early, and I've already given an example of the alpha dystroglycanopathies, and there are some other similar phenotypes. And then we have the myotonic muscular dystrophies. Okay, now these have clinical or EMG myotonia. In very small children, if we do an EMG, we may not pick up the myotonia, but then one of the parents would be a carrier, and you can pick this up by testing the parents. And here you can see that they present with, again, look at this hypotonic look. Look at the face. It's got this downturned lip, inverted V-shaped lip because of the muscle weakness. Look at this bitemporal concavity. And these children have, or patients, unlike other muscle disorders, they will have distal wasting more than proximal wasting. This is and some of them would present like this, especially where it is transmitted from the mother to the child, because you know that this is an autosomal dominant disorder. It is a triple repeat disorder. And I'll talk about that in my next slide. But see, they present with antenatal polyhydramnios. They may not feel good fetal movements. And in the NICU, they would have a delayed cry, so low APGARs, hypotonia, very little spontaneous movement. So there's a lot of weakness. The reflexes are hypoactive because the muscles are involved. And because of decreased movements, they could have club foot. They have respiratory insufficiency. There's no hepatomegaly because you want to differentiate these disorders from children with Pompe disease. At times, they may be, the central nervous system may be slightly depressed compared to Pompe. They can have a mildly elevated CK level. So this we know is a trinucleotide repeat disorder. And because of this trinucleotide repeats, we know that in each generation, in the next generation, the number of repeats keep increasing. And as the number of repeats increase, the phenotype is more severe. When it is transmitted from the mother to the child, it can present in the neonatal period. When it is transmitted from the father to the child, it is less severe. Okay, then we come to the group of congenital myopathies. These are developmental disorders of the muscle. Okay, so the muscle does not mature as it normally should. So they are non-progressive, unlike myotonic dystrophy, which is a progressive disorder. They can be very severe and life-threatening, or they can be milder phenotypes. If they present very early and they're severe, they will again have difficulty in feeding, difficulty in breathing, and plus minus involvement of the heart. So it's all the muscle that is involved everywhere. And here we could do a muscle biopsy, but you need to have all the 3 parameters that I talked about earlier. Or the other thing is do the gene testing to test for the many genes that are involved with congenital myopathies. And some of them, now this is a child with myotubular myopathy, the X-linked form. So you see they need a ventilator at birth, extremely hypotonic, no muscle mass, look at this, how flail the chest is looking. We do the muscle biopsy, you can see these centrally placed nuclei, the Gamori staining, which shows myotubules or centronuclear. So it's called myotubular or centronuclear myopathy. And this is the mutation in the MTM gene. So you made a clinical diagnosis and then you just sequence the gene to identify the phenotype. This is another example. It's an interesting case. So this was the mother and the first child, this child, who had delayed motor milestones, weakness, hypotonia, but cognitively very alert, both of them. And they were confirmed to have Nemelin myopathy due to a mutation in the RYR1 gene. Now, this baby was born, preterm baby, small for date, and his APGARs were depressed, needed some positive pressure ventilation. He was extubated on day 2, but then soon developed abdominal distension and sepsis. Needed an exploratory laparotomy, and after that had a very stormy course. There was scar dehiscence and problems like that. And all the time, maybe the phenotype, this abdominal distension, etc., could have been related to the presence of the myopathy, because this child also had the same gene mutation. Okay. The other thing that this case tells you is that in the same family for autosomal dominant disorders, you could have milder phenotypes as well as severe phenotypes like this child did. So these are the 4 common congenital myopathies: central core, Nemelin, myotubular, and the congenital fiber type disproportion. And this table gives us an idea, can we differentiate them clinically? They will all have hypotonia and weakness. Nemelin and myotubular usually present very early in the neonatal period. Facial involvement is definitely present in them. There is ptosis only in myotubular or centronuclear that I talked about, with extraocular weakness. So this is some sort of a clinical differentiation for these. And then we have these metabolic myopathies. This is a list of them. The ones that I have highlighted, including the mitochondrial, can present early in life. But the one that really presents at birth or in the first year of life, which again needs a diagnosis because of the presence of treatment, is Pompe disease. And these children would have hepatomegaly along with cardiomyopathy and a high CK, with changes on the ECG. And once you have this whole spectrum, you do confirm the diagnosis by testing the acid alpha glucosidase enzyme either in a blood sample or in the dried blood spot, and confirm then, once that is deficient, you confirm that by doing looking at the genes. The GA gene is the gene for Pompe disease. And the other group there is the mitochondrial group, which will again present early on in life. We have clinical diagnosis, metabolic and functional assays, and we know that this is a multi-system disorder. They could present with any organ involvement, and usually it is multiple organ involvement. So you could have cataract, you could have cardiomyopathy, encephalopathy, ptosis, liver involvement. Okay, it's very, very rare that very early on we have only one organ involvement. So, and again, you suspect it because there is multiple organ involvement. If the lactate levels are high or the MRI is showing a lactate peak. So just before I conclude, this was a recent paper that talked about the genetic etiologies of hypotonia in 3 series of 277 patients. And you can see that the central causes were higher, 60 to 80%, versus the peripheral, which were 15 to 30%. The commonest were chromosomal disorders, followed by cerebral dysgenesis. Amongst the neuromuscular disorders, myopathies and congenital myotonic dystrophy were relatively common, whereas SMA, muscular dystrophy, and IM were less common. But of course, in situations where we have endogamy or consanguinity, as we find at least in my country, some of these recessive disorders like SMA would be more frequent. So it's important, we these days come away with a feeling that, oh, we can sequence all the genes. So why do I need to do so much hard work in making a clinical diagnosis? But remember that no test works well without a good clinical diagnosis. And even if we use all resources that are available to us, we can only achieve a diagnosis in about 90% of patients. So the crux really remains a physical exam, a thorough history. More than 50% of the patients are diagnosed by this alone. In the rest, because we have a good clinical phenotype, that will facilitate our evaluation of the genomics data and interpretation of the results. So before I conclude, this is again a recap of my presentation. We start with a history and a fetal examination. The important points we note in antenatal: have to rule out hypothyroidism, and then also look for maternal history of weakness, myotonia, or myasthenia. Look for the central etiology, which the telltale signs of which are encephalopathy, seizures, apnea, dysmorphism. Hypotonia much more than the weakness. Reflexes are never absent in a central cause. We can fit it into a syndrome like Zellweger I showed you, or a Miller-Dieker, or a congenital muscular dystrophy, and accordingly you order the test. The neuromuscular or the peripheral nervous system will have weakness and hypotonia. They can have facial involvement with fasciculation and respiratory muscle weakness. We would want to do a parent examination. The CK levels can be high or slightly or normal. The EMG and the NCV helps us in some disorders. A muscle biopsy you would do only if you have the 3 limbs of the muscle biopsy to make your diagnosis. Remember, it's an invasive, painful test, and you do it only if you have electron microscopy, enzyme histochemistry, and H&E. And of course, the final answer comes with genetic testing. So to conclude, I again would like to reiterate that you need a sound clinical diagnosis to do the correct investigations and achieve the correct results. Determine the level of your lesion and then order your definite genetic diagnosis. I would like to thank you all for a very patient hearing and acknowledge the role of each and every person in my department in Gangaram Hospital, the patients and their families, for all that they have taught us. Thank you very much.
Thank you very much, madam, for the very informative lecture in such a structured approach to the clinical problem. So I think we can entertain few questions because we are left with another 10 minutes. So I suggest you to either unmute your mic and ask the question, or just type your question to the chat so that we can direct it to the speaker. Just one clarification, madam. I want to know, in SMA, you said that we need to know the number of SMN2 gene copies to determine the novel therapies. So can we detect the number of SMN2 copies in the same MLPA, what we do for the diagnosis, or do we have to do a separate test?
No. The MLPA will identify the deletion of SMN1 gene as well as the copy numbers of the SMN2 gene.
Okay. Thank you, madam.
How common do you find SMA in your hospitals and in your practice?
We see quite
many patients. It is fairly common, I think. Yes.
Yeah.
Yeah. And are any of your children on any therapies for SMA?
No, madam. I think we haven't introduced it in Sri Lanka yet.
Okay. So we do have, because I see that there is a question on SMA. So there are 3 approved therapies for SMA, FDA and EMA approved. One is the gene therapy. The second is a drug which is given intrathecally, that is called nusinersen. And the third is an oral medication that is called risdiplam. So risdiplam and nusinersen work on the, they need a certain amount of SMN2 copy numbers for them to function, whereas gene therapy is gene therapy. It is at the gene level. So gene therapy is not dependent upon the SMN2 levels.
Thank you for that clarification, madam. So I don't see any questions in the chat box.
Again, let me thank and let me pay our gratitude to our guest lecturer, Madam Ratna Puri, for her very informative and very elaborative, I feel a very successful webinar, which was conducted with the collaboration of you, Madam. And it was very beneficial for the PG trainees, especially who were logged in from the beginning. I could see, and thank you very much for your kind consideration of our invitation. And let me pay my gratitude to you, madam. Thank you very much. And for this whole program, in the absence even, I would like to convey my dearest heartful gratitude to our leader, Professor Vajira Disanayaka, and all the members of Human Genetic Society and the Human Genetic Unit. Let me thank you all. And all the participants. I'm happy to say that it was exceeding 100 participants here. So even in the some are absent there, I would like to thank all of them. And another announcement that the whole speech by the our guest lecture is available at our Human Genetic Society website, and the link will be shared in the FB page, official FB page of the Human Genetic Society. So thank you very much for all the people, and we would like to conclude by now. So have a nice day by the evening. Thank you very much, madam. Have a nice day.
Thank you very much, and it was a pleasure. And I really appreciate having so many students. So I hope it was useful, and thank you. Thank you.
Okay. Thank you very much, madam.
Good night.
Okay.
Good night.
Good night. Good night.